Mateo County Health is one of California's public health systems, so we're a safety net provider. Our population is primarily covered by Medicaid or Medi-Cal, as it is in California, as well as our uninsured population. We're one of the healthiest counties in the United States. We're one of the wealthiest counties in the United States, but we also, struggle. And we face a lot of challenges with some of our most complex clients. And as a safety net organization, we're fortunate that while we have a medical center and we have clinics, we also have a full behavioral health and recovery services program, provides services to seniors, to disabled kids, all the way down to making sure that the food you eat at restaurants in our county is safe to eat. I've tried to give something back to this organization over the years. I think the most exciting thing that I enjoyed was serving on the annual conference education committee, where you get to not only review and prioritize and present to the HIMSS board the 200 or so educational sessions that are offered here, but you also get to help set the stage. A team of about 15 folks working with a number of the senior executives at HIMSS on the types of education that are offered. And it's something that our team tried to do during the 2 years we were together, was to actually start to address the social determinants of health. We know that folks are addressing these issues across the country, but there just wasn't enough presence. And I'm really glad to see there's a lot more behavioral health and a lot more presentations and lectures on not just interoperability across the traditional hospital and clinic environment, but all the way down to that behavioral health level, looking at housing and looking at access to clean water. It's been heartening. I look at my own situation. I have a family. We all have access to great healthcare services, and I have it all at my fingertips. I can do everything on my mobile app. It's extremely efficient, but that's because the organization where I get my healthcare is on an enterprise platform, and we're not today. We are on a mission to do just that. And the biggest issue I have that is really difficult for me to put myself in our clients' shoes and know that it would be very challenging for me to provide them with the view of their health record without enormous expense, but also really a complicated set of steps and integrations and, if you will, wiring, virtual wiring, that it's not cost effective to do. So we know that we have to make some significant changes in order, with both our customers, our provider network in mind, but ultimately our clients, and how these folks want to consume their own health information so they can make better decisions for themselves. In addition to ultimately moving us to that enterprise electronic health record environment, which we call simply EHR 2.0, it's really trying to leapfrog some of the interoperability concerns we face for the best-of-breed EHR environment today with multiple EHR systems, and that's being accomplished by implementing a health information exchange. We built a master person index a few years ago, and we're about to go live with Health Information Exchange that will initially connect all of our disparate systems together, and seeing it in its near production form today, it's outstanding. I just can't wait for our providers to be able to take advantage of this. But that opens all the doors to all of the other networks, all the industry consortia, statewide and partial statewide HIE solutions, where we can connect across these virtual networks and all share. So it's certainly about us trying to retrieve as much information we know about our clients, but if the flip is also true, where folks may end up in our emergency department, and I want to make sure that whoever that person's primary care physician is has the access to that information as well. I think the first realization that we had a couple of years ago when we started was we really need to understand who all of those stakeholders were. As it turns out, there are so many folks that need to know something about our clients that don't have MD or RN after their name. And so when we started looking at these different networks of folks who are providing services to our clients, it was obvious that in our planning, we needed to make sure we were including roles for community-based organizations where the social determinants of health come into play. Supportive housing is probably the best example, but we know that it's going to be essential for our health information exchange to be able to provide information for those CBOs that are helping house our clients. We know that if folks have a roof over their head, they have a much greater likelihood of not having to consume so many healthcare services from us. Really good day is when I'm able to interact with one of our providers or one of my executive colleagues. We're like, this is what we've been hoping to do for a long time, and we're not trying to make anything an IT project, right? The whole goal of these interoperability initiatives is just for IT to enable a capability to help solve problems. And so a good day for me is when somebody tells me a problem is solved or close to being solved, or they've unlocked the key to a problem or a root cause. Those are good days for me. So we know that in government, our salaries are never at the top end of the scale. And we also know that working in Silicon Valley means that a lot of common roles that are both specific to healthcare but also specific to HealthIT, or just IT in general, like project management, depending on how the economy's doing, the pool of applicants can be pretty thin. And so what we do is we go through our projects before we really dive into them and trying to understand up front, do we really have the expertise anywhere in this county to accomplish this without assistance, and try to go into that before a budget gets generated and before we actually start work, so that we know we kind of go, we're going to need help, and then we're not shy. When we need it, we're going to go get it, because we know that doesn't make sense for a small organization like ours to try and build something on our own. It would take 5 times as long to do it, and it would probably end up costing us more than to go and acquire the assistance when we need it most. I think the organization had help when it needed it, but I also think because it's best of breed and the long haul thinking, a lot of organizations weren't thinking about, well, how do I make all this information shareable even with the people who may work down the hall or upstairs or in the building next door from me. So the way we go about it now is we understand there are lots of folks who have accomplished this, who had bigger staffs and bigger budgets, and we try to learn as best we can from their experiences, but we also know that bringing in external assistance essentially is going to shorten our time to market with whatever solution we're trying to implement. That's hard to tell because our client population is really a niche, and it's primarily serving the underserved. None of us view serving that client population different than anyone else. We haven't seen as much demand for things as I want to see my own personal health record on my smartphone, even though we know plenty of folks have smartphones. We haven't seen the same demand, but I expect that the more we get into things like looking at video visits and being able to have more, if you will, in-between visit care, like how are we keeping up with you, how are we dealing with you as a whole person and not just when you're coming in for an appointment, that's going to make a whole lot of difference in how people will essentially demand more from us as far as access to their health information. And there's a program that we're involved with called Whole Person Care. We're doing just that, identifying some of our most complex clients, a lot of whom face homelessness, a lot of whom who have been stuck in a jail recidivism cycle. And so we're out here trying to provide all of these folks with a different experience, with a very targeted group of care navigators. And if we can be successful there, we can be successful with the people who aren't facing nearly as many struggles.